of dilemmas regarding the disc. I now request Dr. Jayasree to speak about glaucoma in myopia and describe her diagnostic ladder. Dr. Jayasree is presently working as a consultant in glaucoma at the Eye Vision Eye Hospital, Thrissur, formerly with the Narayana Netralaya, and she is an alumnus of Thrissur Medical College. Welcome, Dr. Jayasree.
Good morning. At the outset, okay, it's good afternoon. Good afternoon. At the outset, I would like to thank KSOS and Dr. Jaini for the opportunity. The presentation is on glaucoma in myopia, and both the topics, both the diseases are a very difficult disease. Especially when it combined together, it's going to be a very difficult decision to make. But let's see what are the challenges that you face. But first, about the prevalence. By the end of the decade, you expect around 80 million people to suffer from glaucoma. And what about myopia? By 2050, around 50% of the population are bound to be myopic. And what about high myopia? That is, patients having more than -6 diopter and axial length more than 26.5 millimeter is going to be 10% of the population. And when the time travels to 2050, this is how the globe will look like. Southeast Asia, around 65% or 60% of people will be myopic. So coming to India, what you see, 5 to 15 years, 7.5% of the kids are already myopic, more so in the urban population. By 2050, 50% of the population here are going to be myopic, and many of them glaucoma also. So glaucoma is, myopia is associated with so many other diseases. Glaucoma is one of the main problems. So many population studies have shown that glaucoma is associated with moderate to high myopia. And coming to the type of glaucoma that is associated with myopia, primary open angle glaucoma, normal tension glaucoma, and we should not also forget the pigment dispersion glaucoma, especially the young males with moderate myopia who comes with spontaneous fluctuation of IOP during exercises, and high IOP without field loss, who presents to us with these Krukenberg spindles, the highly pigmented, the coffee brown pigmentation in the open angles of the wide open angles. They have Sandermeyer's lines in the posterior lens, and they can, the ISOCT picture where you see deep anterior chamber, the concave iris insertion, and this is called the reverse pupillary block, where the iris hugs over to the anterior aspect of the lens. This is one condition where PI helps. The patient at presentation can have this bad visual fields. Here, the OCT, what I am trying to highlight is the poor quality of the signal strength. This is not because of the technical error. This is because of the myopia itself. We'll come to that later. The challenges that we face when the myopia is complicating glaucoma is not just in the medical diagnostics, it's also in treatment of the patient. Coming to every aspect of glaucoma diagnostics is given a challenge by myopia. Coming to IOP, which is basic for glaucoma diagnostics, the scleral thinning, poor elasticity of the walls of sclera. These patients are vulnerable because of the scleral tension across the optic nerve head and lamina cribrosa. The lower axial lengths are more prone for IOP-related problems. When the axial length increases, the IOP-independent risk factors also gives a more challenge. Younger myopes are known to have higher daytime IOP, higher nocturnal supine IOP elevation, greater IOP fluctuation after exercises. And what about the post-refractive status of the patient? Most of the patients nowadays with myopia have undergone a refractive surgery. You have to ask the history of a refractive surgery and look for corneal thickness. And this is not sufficient. You have to look for the elasticity, hysteresis of the patient. And what about the IOP status? If the IOP is more than 20 millimeter of mercury, and if the axial length is 25.5, that itself is a risk factor for glaucoma. And when they act together, they are not simply additive, they are also synergistic. So that means these together can increase your risk for glaucoma by 16 times. And this is a patient who was put on all the medications possible, and she has presented with allergic eye disease. And the patient had probably a normal myopic disc and a normal visual fields. And the IOP, the point I wanted to highlight here was the patient had LASIK and the corneal thickness was very low. Coming to optic disc, all these problems of scleral thickening, axial length, elongation, everything is there, and with this you have to see the optic disc. You can see n number of variations of optic disc presentation. To find out your normal CDR, your normal ISNT and all is not going to happen in an optic disc when you have myopia. What all presentation can be there? Larger disc, tilted disc, shallow cup, nasal insertion, peripapillary changes of all forms, the gamma atrophy, beta atrophy, everything can be there. ISNT is never followed. You cannot see an RNFL defect because you have a severely tessellated background, and optic disc area increases with the refractive error of the patient. It is very difficult to judge. You have to have a high index of suspicion. All myopics, you have to look for glaucoma. It has to be a dilated 90-day examination. You have to have detailed serial stereo photography. Compare every time. Progression always favors glaucoma. Look for disc hemorrhages. If there is a disc hemorrhages, highly likely that the patient have glaucomatous damage. Coming to OCT, does the imaging help you? The normative database does not go beneath minus 12 diopter. So you don't have data beneath minus 12. What happens to highly myopic eyes? You don't have the good RNFL characteristics. They are flagged off. Poor image quality is a problem. Dissimilar database is a problem. And the average RNFL thickness itself reduces. 7 micron reduction happens for each 1 millimeter increase in axial length. For 1 diopter increase, minus 3 microns reduces. You have heard about red diseases. When you have no disease, but the imaging system diagnoses it as a disease. That is red disease. No disease, but the system says it's disease. And high myopes are more tend to have this problem because of the imaging issues. Segmentation errors. When the system algorithm measures the thickness and the target retinal layers, the thickness is measured. And if a problem happens in measuring of the thickness of the layers, as in high myopia, tilting of the disc, peripapillary atrophy, myelinated nerve fibers, then again the errors happens and the red areas are highlighted. Here again, there is no disease, but that is how could I see that there is no disease? Because especially in the right eye, every area is red here, but the HFA is normal. What problem else do you see here? There is displacement of RNFL peaks. You can see that there are good peaks here, but it is displaced temporally. So displacement of temporal, that elongation happens and temporal displacement of the RNFL peak happens. In hyperop, it comes together, nasally displaced. And this nasal temporal displacement leads to inferior red disease. Macula OCT is another promising tool because it is less affected by elongation of the globe and it is more reproducible. And GCC with the temporal raphe, that horizontal demarcation where you lose GCC and it is horizontally demarcated, it is called temporal raphe. If you see a temporal raphe, it is highly possible that it is a glaucomatous eye. What happens in visual fields? Myopia have threshold sensitivity which is low, and there are defects that favor myopia and defects that favor glaucoma. And enlarged blind spot is a defect that favors myopia. So even if you have a normal, there are certain proportion of myopic patients who can be misdiagnosed as having glaucoma, and they might end up taking unnecessary treatment. So this 10% have glaucoma-like defects in spite having a normal myopic disc. So you should be always be open to have, if the patient is not progressing, be open to change the diagnosis of glaucoma from that patient. You should be open to reducing the medication. So what about this eye? You can see that the right eye has enlarged blind spot. Between the eyes, the disc does not look very dissimilar, but the left eye definitely has a superior defect. But then I will rather closely follow up the patient. Maybe I'll put the medication for the patient in the left eye, but I'll rather closely follow up the patient. If the patient is not progressing, I'll rather safely observe the patient, close observation. Progression favors glaucoma. Field defects continue to progress in spite of good IOP control because of the possible fluctuations. Myopia itself is a risk factor. Migraine, sleep apnea, anemia, hypotension all adds to the risk factor. Just a word about surgery. Hypotony is a major risk factor. So it's a tight balance between hypertony and hypotony. Mix is a promising surgery because the flap is not involved. I'll just take a minute on the take-home messages. There is a strong link established between myopia and glaucoma. Myopia is a mimicker in all parameters of glaucoma, so it poses challenge from IOP to imaging and visual fields, a high index of suspicion, a longitudinal follow-up, and looking for progression helps you diagnose glaucoma and myopia. Important when you plan surgery is remembering hypotony. So if you don't have your techniques correct, you are bound to fall from this ladder. Thank you for your patient listening.
Thank you, Jayasree, for that great, wonderful presentation.